Good evening, everyone. My name is Mikias Gabriel, and I am licensed physical therapist with over 3 years of experience. I have worked in outpatient medical center abroad, specifically in Ethiopia, Addis Ababa, called Optimum Physical Therapy Specialized Clinic. And currently, I'm working as a full-time physical therapist in an outpatient medical center in the United States of America, Colorado, Aurora. So I'm also a student in College of ST Scholastica, pursuing my transitional Doctor of Physical Therapy program. Today's presentation is part of our spring semester course on pharmacology for physical therapists, and I'll be discussing with you guys about the definition of frozen shoulder or pathophysiology, clinical presentations, and management of frozen shoulder. Before I begin my presentation, I will give you the chance to tell about yourself. So, uh, if, if anyone is not feeling comfortable, that's fine. But I'll start from Sami uh, or other colleagues. So, are you guys listening my presentation right now? If you are listening, you guys say okay or uh, say okay in your chat. Okay, Sam is listening, Nadi is listening, Nati. Okay, all right, I'll start from Nati.
Hello everyone, I'm Nathaniel. I'm physiotherapist at University. Thank you.
Okay, I'll give the chance for Nadi.
Hello everyone, I'm Natos. I'm pharmacist.
Thank you, Nadi. Uh, okay, I'll give the chance for Sami.
Hello, everyone. My name is Samuel Tafri from School of, University of Gondar, Ethiopia, and I'm a physiotherapist with over 5 years of experience, and I'm senior physiotherapist and lecturer at University of Gondar.
Thank you, Sami. Thank you, everyone. Uh, I'd like to sincerely thank you, each and every one of you, for being here today. Uh, guys are my friends, my colleagues, especially Sami. He's my former classmate at the University of Gondar. So your presence here, your presence and support means a lot to me. So I'll start my presentation. So my title for for this project is Pharmacological Management of Frozen Shoulder in Rehabilitation. So, frozen shoulder. Frozen shoulder. So you can see the image here. Before I come to the image, I'll discuss the definition of frozen shoulder. Frozen shoulder is also known as adhesive capsulitis. It's a common debilitating disorder characterized by shoulder pain and stiffness in the shoulder joint. The condition results in development of thick and fibrous joint capsule, contraction of the joint, and reduced intra-articular volume. Frozen shoulder characterized by a progressive loss of movement, both active and passive range of motion. So here, frozen shoulder, as you see here on the picture, it specifically affects the shoulder capsule. The other name of frozen shoulder is also adhesive capsulitis. That means inflammation of capsule. We can say capsulitis means inflammation of capsule. So the AI generated image I did myself in April 6. So the reason I used the female, an old lady, is due to the pathophysiology. So today's learning outcome uh, focuses understanding the clinical significance of frozen shoulder. Uh, we need to differentiate between primary and secondary frozen shoulder. We'll also discuss the stage of frozen shoulder and their typical frame, uh, the risk factor, and underlying pathophysiology clinical manifestations, how to diagnose frozen shoulder, including clinical evaluation. So we will also discuss both pharmacological and non-pharmacological managements. So the content are as I told you about frozen shoulder classifications, the pathophysiology, prevalence and risk factor, symptoms, diagnosis, management. So if you guys have any question, you can type question or something in the chat box. So then you can feel free to ask any question about the presentation. So when it came to type of frozen shoulder classified into primary frozen shoulder and secondary frozen shoulder. Primary frozen shoulder occur without clear cause or idiopathic. It's often associated with a metabolic condition like diabetes. So people with systemic conditions such as a thyroid disorder, Parkinson's disease are also more likely to develop frozen shoulder. Also, when it came to secondary frozen shoulder developed due to might be prolonged mobility, such as rotator cuff tear, shoulder impingements, biceps tendonitis, and calcific tendonitis. When we came to pathophysiology, frozen shoulder typically develops through three main overlapping stages. We can classify as a freezing stage, frozen stage, and thawing stage. Freezing stage is the most painful stage. It's a gradual onset of diffuse, and it is known by severe pain. It lasts 2 to 9 months. Also, second stage is frozen stage. The pain will begin to subside with characteristic progressive loss of glenohumeral flexion, abduction, internal rotation, and external rotation. So this stage lasts 4 to 12 months, and the last stage is stage 3 or thawing stage. The patient experiences a gradual return of range of motion lasting 5 to 24 months. So when we came to prevalency, frozen shoulder affects between 2 to 5% of the general population. As I told you, strongly linked to diabetes mellitus. Frozen shoulder most frequently seen in women, particularly among individuals aged 40 to 70 years old. So that's why in a previous image, I generated the AI a picture of old woman uh, with shoulder pain. So the pathophysiology of frozen shoulder is not clearly established. It is generally believed to begin as inflammation that leads to cystic fibrosis, contraction of the shoulder with synovitis. So when we came to risk factors, diabetes is a leading cause of frozen shoulder. Also, low body mass index, cervical spondylosis, hyperlipidemia, and common risk factors associated with the current frozen shoulder. So this is according to 2024 research topic. So the other risk factor is hypothyroidism. Thyroid disease also increase the risk factor by two time more. So the other risk factor is Parkinson's disease, and the final risk factor is prolonged immobilization. So as we discussed, prolonged immobilization is a secondary frozen shoulder. So when we came to pain associated with frozen shoulder, the symptom. So the pain is the most limiting factor. Pain and stiffness. It affected the ADL activity of the person, impair the sleep quality, which can contribute to the feeling of depression and anxiety. The hallmark of frozen shoulder are pain and stiffness. So when we came to a diagnosis. Diagnosis is primarily clinical, heavily based on physical examination, and relies on identifying global motion restriction and pain. According to Miller and ETL 2022, less than 100-degree flexion, less than 10-degree external rotation in a bridge behind back. So I've seen a lot of patients with this clinical scenario in my everyday clinical practice. Currently, I would say I see two people per day with frozen shoulder, so I'm pretty familiar with the condition. It is also advised to get plain X-ray to rule out bone-related issue. X-ray help to identify other potential condition if there is a joint disease or calcific tendinitis or if there is fracture. While additional imaging like MRI and ultrasounds are not always necessary, they can be helpful in situations where the diagnosis is unclear. So MRI usually shows if there is a rotator cuff injury or other soft tissue related problems. So we can differentiate the diagnosis of frozen shoulder with other problems. So when we came to the management of frozen shoulder, the management of frozen shoulder begin with patient education, as explaining the natural course of the condition often help reduce frustration on patients, so it will improve compliance and ease the patient's concern. It's also important to acknowledge that full restoration of range of motion may not be always achievable. So if you guys explain or educate the patient about the natural course of the progression or the condition, patients may not be frustrated. So the management decision should be agreed with jointly with the patient and also with clinician based upon comorbidities, severity, and natural history of the condition. So when we came to frozen shoulder management, there are two types of management mainly. The first one is conservative management. The other one is surgical management. So usually frozen shoulder uh, managed in a conservative way. If the conservative management doesn't work, the patient would be most probably referred to surgical management. So when we came to conservative management, we can classify as a physical therapy treatment as well as pharmacological management. So when it came to pharmacological management, we can use nonsteroidal anti-inflammatory drugs, corticosteroid injection. Also, there is oral non-steroidal anti-inflammatory drugs, and oral corticosteroid injections. So the other conservative management is hydrodilation. It's the capsular extension. When I came to surgical management, there are some type of surgical management is, but we cannot focus today because this presentation focuses on pharmacological management of frozen shoulder. So I will not discuss about surgical managements. So this picture shows how a physical therapy management look like. In a picture, this image is generated from Adobe Experience using AI. I did generated this picture. The ladies, you can assume as a physical therapist, and the old lady as patient. So I use the patient as old lady because of the pathophysiology. Okay, physical therapy management. Physical therapy techniques and home exercise can serve as effective initial treatments. So we can use as a first line treatment. Physical therapy technique improve uh, patient's range of motion, enhance functional status, uh, reduce pain, and uh, especially in freezing stage, and patient can benefit from pain relief technique for pain management. So the physical therapy management also include rotator cuff strengthening, dynamic scapular recognition exercise, sustained posterior stretching. When we came to the physical therapy management, uh, this is different from stage to stage. Like in a freezing stage, we can use gentle shoulder mobilization, pendulum exercises, passive range of motion exercises, pain-free active assisted movement should be performed. In frozen stage, we will maintain stretching exercise and adding strengthening as well as so when we can use isometric and static exercises as strengthening exercise. In a thawing phase, the patient experiences a gradual return of range of motion and the pain will be decreased on thawing phase. So strengthening exercise is crucial to regain full range of motion. So according to 2021 systematic review, evidence indicates that some physical therapy techniques such as rotator cuff strengthening, dynamic scapular recognition exercise, sustained posterior stretching, Mulligan technique, whole body cryotherapy, extracorporeal shock wave therapy, and addition of lidocaine injection to standard physical therapy are highly effective for pain relief, improving range of motion, enhancing functional status in patients with adhesive capsulitis. So, while others are only moderately or mildly effective, but those exercises are highly beneficial according to systematic review and meta-analysis 2021. When we came to pharmacological management, the first one is non-steroidal anti-inflammatory drugs. It's primarily used for short-term pain relief, inflammation control, improved shoulder function and motion, according to 2024 research. So we can use oral non-steroidal anti-inflammatory drugs. However, we have to know that uh, oral non-steroidal anti-inflammatory drugs has side effects which affects gastrointestinal, cardiovascular, urinary system, and other. Do you guys have any question? Is it clear? Okay, I see all is clear in chat. Thank you. Okay, I'll continue. So, corticosteroid injection lead to significant short-term improvement compared to the other non-surgical treatments. So I will come in detail in the next slides. So early use of corticosteroid linked to a better result, especially when paired with home exercise programs. Also, the other conservative management is hydrodilatation. Uh, it's hydrodilatation means a technique involves dilatation of capsule with either saline or steroid or local anesthesia in attempt to stretch the capsule. So, as we said, the other name of frozen shoulder is adhesive capsulitis. So the hydrodilatation is used to stretch the capsule in order to break down any adhesion. Non-steroidal anti-inflammatory drugs. It's widely used for pain management by reducing inflammation and pain with mechanism of action, inhibition of cyclooxygenase enzyme, which decrease prostaglandin synthesis. So there is a selective and non-selective non-steroidal anti-inflammatory drugs. So from selective NSAIDs, there are ibuprofen, diclofenac, naproxen. And from selective non-steroidal anti-inflammatory drugs, we can see celecoxib and other one. So as I told you, non-steroidal anti-inflammatory drug, uh, it's up for short-term course, usually 2 to 3 weeks, commonly used to reduce intense pain during freezing stage of the frozen shoulder. Okay, oral steroids. When I come to oral steroids, oral glucosteroid can be used safely up to like 1 milligram, usually prednisolone for inflammatory condition. This is not specifically for frozen shoulder, it's for general inflammatory conditions. For frozen shoulder, we can use up to 40 milligram per day. It's beneficial for frozen shoulder. Commonly used corticosteroid help to reduce inflammation, relieve pain, improve shoulder function. We can, for example, long-acting glucocorticoid, 20 milligram, triamcinolone, acetonide, prednisolone. The name is a little bit harder in order to pronounce. So excessive use of corticosteroid may lead to a local and systemic complication such as hyperglycemia and cartilage degeneration. So when I come to oral steroids, they have demonstrated a beneficial in treating frozen shoulder. According to double-blinded, placebo-controlled, randomized clinical trial, patient who took 30 milligram of oral prednisolone daily for 3 weeks showed greater improvement in disability, active range of motion, and overall pain compared to the placebo group. Okay, corticosteroid injection. We have discussed about steroidal anti-inflammatory drugs, oral and oral non-steroidal anti-inflammatory drug, oral corticosteroids, now corticosteroid injection. Compared to oral corticosteroids, corticosteroid injection are better option for reducing local inflammation, offering target relief with fewer systemic side effects. So corticosteroid injection inhibits capsular fibrosis by reducing the synovial inflammation. It's commonly used for soft tissues injection, commonly used for soft tissue, tendon bursa, and standard and used for other standard treatment practices. So we have to know like local soft tissue and intraarticular steroid injection can elevate blood glucose level. This is a side effect of direct corticosteroid injection. So we have to know the complication, especially for patients with diabetes mellitus. Okay, so side effect of intraarticular steroid injection, pain on injection site, it's obvious, flushing, menstrual irregularities, headache, rash, among all flushing being somewhat more common and severe in high dose groups. So we have to make sure we are using a proper dosage. According to 2020 systematic review and meta-analysis of 65 studies involving 4,097 participants with 34 studies in pairwise meta-analysis and 39 studies in network meta-analysis. Intraarticular corticosteroid injection uh, showed a greater short-term benefit compared to other non-surgical treatments with effect lasting up to 6 months. Combining corticosteroid with home exercise program, electrotherapy, passive mobilization may enhance the outcome. Early use of corticosteroid in patients with frozen shoulder during less than 1 year is linked to the better result, especially when we paired with home exercise program to optimize recovery. Overall, corticosteroid injection for the treatment of frozen shoulder result in short-term improvement in pain and range of motion. So, from the last conservative management, I will discuss hydrodilatation. As I told you, it's the technique involves dilatation of the capsule with either saline or steroid in local anesthesia. So we don't have to discuss again on this part. So in order to confirm the use of hydrodilatation, according to the 2023 systematic review and meta-analysis, uh, included 2,623 participants with study size ranging from 22 to 250 participants, among them 1,187 patients with reported data 2024. 224 had a diabetes. So diabetes is a common risk factor. So the review evaluated hydrodilatation for frozen shoulder focused on pain, stability, and range of motion. So hydrodilatation showed early improvement in disability and short to long-term benefit in passive external rotation. So finally, in conclusion, we have to generalize frozen shoulder. The other name is adhesive capsulitis. It is a complex and debilitating musculoskeletal condition marked by shoulder pain and progressive stiffness. So the exact pathophysiology remain unclear, widely accepted to involve inflammation, fibrosis, and capsular contraction. Frozen shoulder progresses through 3 overlapping stages: freezing, frozen, and thawing stage. So each clinical characteristics and treatment is unique. Also, the diagnosis primarily relies on clinical evaluation with imaging used to rule out pathologies. The condition is more prevalent in individuals for aged 40 to 70, strongly associated with systematic disease, particularly diabetes and thyroid disease. Finally, the natural course of frozen shoulder may resolve over time, can significantly impact function and quality of life. So early education, pain control, maintaining mobility through physical therapy are vital components of effective management. The pharmacological interventions such as NSAIDs, corticosteroids, hydrodilatation offer short-term relief but do not change the long-term course. Surgical options are reserved for refractory case despite ongoing research. Their surgical management remain no universally superior treatment, underscoring the importance of patient-centered, phase-specific, multidisciplinary approach. So continued research and individualized care are essential in improving outcome for patients suffering from frozen shoulder. Finally, thank you for listening my presentation. There is references at the end of the slide. So I have used more than 20 something references uh, in order to figure out how frozen shoulder uh, affect our body, management, pathophysiology, and everything about frozen shoulder. You guys have any question? If you have any question, you are welcome to ask any question. Is all clear? You can thumb up. Sami, do you have a question?
Thank you, Miki, for preparing such interesting and very helpful and informative presentation. Yeah, your PowerPoint was so clear and eye-catching and easy to read and to attend. So you provided, most evidence-based and latest practices, especially in addition to physical therapy management for frozen shoulder. You incorporated the pharmacological management, which I get new and helpful evidences how to manage the pain and range of motion limitations secondary to frozen shoulder patients, right? And the other is I found, usually I experience many patients, I like visit, many patients visit our outpatient department, physiotherapy outpatient department for having this frozen shoulder case. And they complain, especially the pain and range of motion limitations. So we usually apply like pain management other than pharmacological. But in this presentation, I've got something new, like to treat the pain and to limit the inflammatory progresses. So I found this more relevant, and it applies and it eases and enhances the progress and treatment outcomes, right? And I really appreciate the you provided lots of evidences, latest evidences, the best treatment that works for the patient. So I've got this presentation very helpful and informative. So I'd like to thank you, Miki, for your nice and evidence-based presentation. So this is all I got. And as a question, maybe you provide like the treatment options based on their severity, based on their stage. So what makes those stages different from each other?
Okay, good question, Sami. So when we see the pathophysiology of frozen shoulder, that they differ in three ways. So the first stage is freezing stage, the second stage is frozen stage, and the last stage is thawing stage. So when I came to the freezing stage, the pain lasts between 2 to 9 months. This is the most painful stage. and the main complaint for the patient is pain at this stage. So the range of motion may not be limited that much like a thawing stage and frozen stage, because the main complaint on this stage is pain. So we will usually start with non-steroidal inflammatory drug in order to manage the inflammation uh, at the first stage. So when we came to towing stage, also when we see the physical therapy management is different from the stage to stage. So the pharmacological management also different, the physical therapy management also different in each stage. So when we came to the second stage, frozen stage, the pain becomes subside slowly. So the pain subside, however, there is a progressive loss of glenohumeral flexion, abduction, internal rotation, and external rotation. So external rotation and abduction is the main difficult thing for the patients. So if we try to externally rotate the shoulder, is difficult and most painful. At this stage, we'll focus as physical therapists. We will focus stretching, progressive stretching. We can see the physical therapy management. So in frozen stage, we will maintain stretching exercise, and we also add some strengthening exercises such as isometric, static exercises. Those exercises are beneficial. So when we came to the third stage, it's a towing stage. The patient experience gradual return of range of motion. So the pain will decrease on this stage and range of motion gradually returns. This stage lasts for 5 to 2 years, 5 months to 2 years. So when we see the physical therapy management in towing stage, so we need to strengthen, we need to use strengthening exercise in order to regain full range of motion. So as I told you, during the stage, our treatment is also different. Is that clear, Tommy?
Yeah, of course, you provided a lot of information, and that makes my clear for my questions. Thank you.
Thank you, Sammy. Right, so if you guys don't have more question, we'll end our presentation. So thank you everyone for being here. I really appreciate uh, your support. In future, I might see you in another course. Thank you so much.